My name is Hillary. I'm a physician. It's nice to meet everyone. I work for Community Medical Services, which is an organization of opioid treatment programs or methadone clinics, which are in the Milwaukee area and in other areas of Wisconsin. I'm trained in family medicine, and then I did a subspecialty, a fellowship in addiction medicine, because that's my favorite thing, and I've just done addiction medicine ever since. I talk really fast. It's not on purpose. I'm not nervous. It's just kind of how it goes. But if you signal me with this, I will know what that means. Okay, so I'm going to be talking about medications for opioid use disorder. I thought we'd start with some figures, or rather some stats. So, okay. So what we have here is we're looking at our drug overdose deaths over time. We're starting in 1999, and this data ends in 2021. I think the main thing here is that starting in 2014, we started to see a significant increase in the amount of deaths from synthetic opioids, primarily fentanyl, and we've seen that basically skyrocketing ever since. I think another thing to know about this, if you combine motor vehicle accidents and suicides, they only kill 84% as many people as opioids do, or as overdoses do, and opioids are a factor in 7 of 10 overdose deaths. So, okay. So when we're thinking about addiction, it's important to define, how do we diagnose addiction, right? How do I, as a doctor, diagnose addiction? I use the DSM-5 criteria. It can be summarized with the 3 C's. So cravings, use despite consequences, and loss of control. Cravings, I'm thinking about a glass of wine, I'd really like to have one. Loss of control, I went to the bar, I thought I'd have 2 drinks, but I accidentally had 8, and I blacked out. Use despite consequences, every time I drink, I fight with my wife, and I keep drinking anyway. But what that tells us is that it's not the use of a substance that creates an addiction, it's the behavior around the use of that substance. Otherwise, everybody that drank alcohol would have alcohol use disorder, but we know that's not true. The reason I bring that up is we're going to be talking about, again, medications today for opioid use disorder. Those medications are opioids, right? Methadone, buprenorphine, the main medications that we use are opioids. Heroin and fentanyl, also opioids, right? So what makes these different? The behavior around taking them. So I would be remiss if we didn't start with talking about opioid withdrawal, because this is the crux of the matter, right? So when someone is taking opioids for a period of time that looks more like weeks to months, not days to weeks, right? So if you just had a broken bone, you had 4 oxycodone at the emergency room, this would not happen to you. But if you're someone who's getting opioids chronically for chronic pain and you're taking them for weeks, months at a time, your brain is going to rewire around having opioids on board. And then if you start to take them or stop taking them, you are going to get very, very sick. The same thing happens with alcohol. It happens with benzos like Xanax, and it happens with caffeine, right, which we're all probably familiar with. If you stop taking caffeine when you've been taking it every day, you'll get a horrible headache. Now, if you stop taking opioids abruptly, you will get more than a horrible headache. You will get viciously ill. Now, a key point, if you are in opioid withdrawal will not kill you. There are some withdrawal symptoms or syndromes that will kill you, like withdrawal from alcohol, withdrawal from benzos. Both of those things can cause uncontrolled seizures, and uncontrolled seizures can cause a person to die. Opioid withdrawal, you will not die from alone. And I think that's important to know, because if somebody goes to the emergency room and their only presenting complaint is opioid withdrawal, they will get turned away. Generally speaking, they will not get any treatment because this doesn't kill you, right? They'll just be like, oh, you're going to be fine. You'll just have to sweat it out and nothing will be done. And so people who are in withdrawal often don't present for medical treatment because they're used to their symptoms not be taken seriously. But I think I want to impress upon you guys, while this won't kill you, that doesn't mean it doesn't completely suck. So as we can see here, withdrawal symptoms they happen along a spectrum, right? They peak 72 hours out, depending on how long acting of a substance you're taking. When someone is in mild withdrawal, you can generally tell because they're kind of antsy in the chair. Like if you're talking to them as a medical provider, they might look a little sweaty, they might start yawning. When someone's withdrawal symptoms are progressing and they're getting more intense, people have uncontrolled sneezing, they have tearing from their eyes, they'll become enormously sweaty. They'll sometimes start pacing if you're in the room with them. And when people have peak opioid withdrawal, they typically have uncontrolled nausea, vomiting, and diarrhea. And sometimes the restlessness that people feel, like the jitteriness that I mentioned, it can get so profound that people have difficulty walking because of the twitching in their legs. So all that being said, not life-threatening, but still really, really horrible. And I think the reason that's important too is because I think about this. I think about the most sick I've ever been in my life, which is one time when I had the flu. And I think to myself, if I had known that all I had to do to keep from getting that sick was something I had done 1,000 times before, it would have been incredibly difficult not to do that thing, to stop myself from getting that sick. And after you've gone over the peak here, it's not like that you're in the clear. right? People continue to have emotional symptoms like depression, anxiety, irritability, agitation. They can also have insomnia, and those can linger for weeks to months. So even though you get over the hill, so to speak, that doesn't mean that you, I guess that you're good to go and you can just go out in the community and you can do whatever you were doing before, because you are not going to feel right. You are probably not going to feel right for months. So what is our solution? It is the medications, the MOUD treatment modalities. So, sorry. I think I might be missing some parts of this. So I might narrate some things for you. So basically,
so they copied over our presentation into one presentation. I wonder if some of it didn't come over.
And no worries at all, because I can do this. But so this says A, because above it there was supposed to be a Q for a question, right? And so the question was, the question is, yeah. It's no. I got this. I've memorized these. We're good. The question is, what are medications for opioid use disorder, right? Because that's the whole point. Specifically, I'm talking about methadone, buprenorphine, which is the main ingredient in Suboxone, Subutex, Sublocade, and Brixadi, and naltrexone, which you may know better by its brand name Vivitrol. These are medications for opioid use disorder. As I mentioned before, the methadone, buprenorphine, they're opioid agonists. They turn on the opioid receptor, right? So they bind the receptor, they turn it on in the brain, the same receptor that heroin and fentanyl bind. Okay, so I thought we'd talk a little bit more about outcomes before we talked about how the medications work. So I think traditionally, for many, many years in our country, when we were treating people for opioid use disorder, the go-to treatment was detox, right? We would just have people stop taking opioids. They'd go through that horrible opioid withdrawal hill that I showed you before. They'd come out the other side and we'd be like, you're good, right? Go out there and be a sober person. And so the question is, does that work? And the answer is no, that does not work very well. So more than 90% of patients with an opioid use disorder return to opioid use within 1 year of utilizing abstinence-based treatment, right? So basically we have a 90% fail rate, which I think is abysmal if we're thinking about the efficacy of a treatment. Additionally, when you go through detox, you lose your tolerance, right? Tolerance being that when you're taking an opioid, you need more and more of that opioid over time to get the same effect as you did in the beginning. Also happens with caffeine. So if you go through detox and you lose your tolerance, when you're finished with detox, you are much more likely to overdose and die if you relapse, because tolerance is protective. To give you an example of that, if I am going to jail, and before I go to jail, I'm using a half gram of heroin a day, and I go to jail, and then I'm in jail for 6 months, I'm probably thinking about heroin a lot, because jail is not any fun, right? And often when people leave jail, they use heroin almost right away, within the 48 hours. If I use a half gram of heroin, because that's what I used before jail, I will die, because I don't have tolerance anymore, and that's simply too much for me. But if I got medication in jail, it would maintain my tolerance, and then if I relapsed, I would be much less likely to die. The same thing is happening with detox, and essentially the point is that tolerance is protective. But the other point here is that not only is detox ineffective, it has the potential to harm people by increasing the risk of overdose and death. Now, this last point is a quote from one of my favorite studies. It says, "Abstinence-oriented interventions are effective for only a few motivated patients with stable living conditions and adequate social support." And I think the point of that for me is that people can succeed with detox. People definitely do succeed with detox. But when I look at my patients who have succeeded that way, they have so many things going for them in their lives that so many of my patients do not. They often have sober social circles, they have involved families, they are housed, they have careers they are hoping to return to. But these are not things that most or the majority of my patients have. Now, on the flip side, if we're looking at the outcomes for medication, people who are on medication have a 4 to 8 times lower death rate compared to those who are untreated. If you have 10 people who have an opioid use disorder and they do not receive treatment, then over a 10-year period, 4 of them will die, right? So opioid use disorder has one of the highest mortality rates of any chronic medical condition, but MOUD decreases that mortality rate significantly. And additionally, if someone is incarcerated and they're kept on medication while incarcerated, the risk of dying after they leave prison is reduced by 75%. So this is basically a summary of outcomes. I like to say that the point of this is that MOUD makes a lot of bad things less, here on the left, and a lot of good things more, right? So overdose, relapse, crime, mortality, IV use, infectious disease, urine drug screens positive for illicits, all those things are less when people are on medications. Employment, housing, stable relationships, custody of children, all of those things are research proven to be more or increased when people are on medications. I added this slide for you guys. I know that that MOUD is being introduced in like correctional settings in our county, so I thought we'd look at some outcomes here. One thing to know is that opioid use disorder is considered a disability under the Americans with Disabilities Act, right? When someone is incarcerated, they are, it is the responsibility of the prison to provide them with treatment for their disability. So when cases go to court and are prosecuted where correctional systems do not provide medications for the people in their care, we have seen that the correctional systems lose, right? It's considered cruel and unusual punishment not to treat people for chronic medical conditions. So I guess the thing to know about that then is that correctional facilities are legally obligated to provide MOUD. And the point of this slide is, why should they want to? So with MOUD, we see less recidivism, less rearrangement, less reincarceration, less post-incarceration overdose, less post-incarceration opioid use, and decreased lengths of prison stay. We also see increased post-incarceration treatment engagement. So how do these medications work in the brain? Okay, so first things first, what are our goals, right? How do we know that we're at the right dose of medication? 24 hours goes by in between doses, and people are not in withdrawal. They're also not sedated, they're alert. We're hoping to block the euphoric effects of other opioids, and we're also hoping to treat cravings. I bring that up because sometimes people think that if you're on a medication for opioid use disorder, it makes you drowsy or makes you sedated. This is not true. The medication should make you awake and alert, like me right now. I would say that is what the vast majority of our patients want. If someone is drowsy from medication, it means the dose is too high and we need to come down. So methadone. When methadone is provided in an opioid or at a methadone clinic, it's provided as a liquid, simply because it's harder to smuggle a liquid out of the clinic and get it to someone that's not supposed to have it. So methadone is an opioid, right? It binds the opioid receptor in the brain, just like heroin, fentanyl, and oxycodone. It turns the receptor all the way on. That's good because it maintains tolerance. Other key thing about methadone is you don't have to be in withdrawal to start it. That's very important because you do have to be in withdrawal to start some of the other options we're going to talk about today. Because methadone is an opioid and a full agonist, meaning it turns the receptor all the way on, you can overdose on methadone by itself. So when we're going up on methadone, we tend to be cautious as we're increasing the dose, and we want you to see a medical provider fairly regularly. Methadone is long-lasting. The average half-life is between 24 and 30 hours, and we like that, right? Because it allows people to dose once a day. Additionally, methadone does have a blocking effect. Now, all opioids have a property called affinity, A-F-F-I-N-I-T-Y, and it's essentially how tightly opioids bind to the opioid receptor. So some opioids bind like spandex, and some opioids bind like loose cotton tees. So methadone binds pretty tight. It binds tighter than heroin. So when we just had heroin on the street, if you were at a dose of methadone that was like 80 to 120 milligrams and you tried to use heroin on top, you simply wouldn't feel anything. The heroin would not be able to knock the methadone off the receptor and bind instead. We liked that because patients would come in and say, I bought heroin and I didn't feel anything. And you'd be like, yeah, it's because it didn't work. And they'd be like, I wasted my money. And you'd be like, yes, right? And that would discourage people from doing it again. But that's part of the reason fentanyl is so tricky. Fentanyl binds very, very tight. So while methadone will block some of the effects of fentanyl, it is never going to entirely block the effects of fentanyl. There's also no dose limit on methadone. You can increase methadone indefinitely to meet someone's opioid tolerance, and that's really important because opioid tolerance has no limit either, right? Fentanyl is a very strong opioid. We are seeing people with much higher tolerances than we did 10 years ago. So it is critically important that methadone is available because there are some patients who will simply not be able to stabilize on other medications.
I'm sorry about your slides.
Oh, don't be. I got this. Okay. So buprenorphine. Buprenorphine is the main ingredient in Suboxone, Sublocade, Subutex, and Brixadi. It is also an opioid, also binds the opioid receptor, but binds the receptor halfway, right? If it were a light switch, it would turn it halfway on. That's important because in the traditional way that you would start buprenorphine, you would have to be in withdrawal to start it. The reason for that, so buprenorphine binds very, very tight, right? Very high affinity. If you came into my clinic and you used heroin an hour before, all of your opioid receptors are covered by heroin. If I give you buprenorphine, it will knock all the receptors off because it has a higher affinity, and then it will bind to the receptor instead. So all of your receptors will go from being 100% activated by heroin to 50% activated by buprenorphine in the span of minutes, and you will get very, very sick. So people have to be in withdrawal before they start buprenorphine in the traditional manner, or it will make them sicker than before. Now, that's another reason fentanyl is challenging for us, because if you were using something like oxycodone or heroin, you need to be in withdrawal for like 16 to 18 hours. But if you're using fentanyl chronically, you need to be in withdrawal for at least 24 hours. And I would say 36 is even better. And that's just honestly a monumental amount of time for people to wait when they're letting themselves get progressively sicker and sicker. It's very, very difficult to let yourself get that sick. All right. Buprenorphine has a ceiling effect, meaning when you're at max dose buprenorphine, all of your receptors are bound, and adding more buprenorphine really doesn't do anything else. So buprenorphine has a max dose of 24 milligrams. Adding more buprenorphine doesn't really, as I said, do a lot extra. So if you are on buprenorphine 24 milligrams and you're still having withdrawal, you may need some, or because you have a higher tolerance, methadone may be the next best option for you, because methadone can be increased indefinitely while buprenorphine cannot. Another thing about that ceiling effect, at buprenorphine's max dose, its maximal effect is below the threshold for respiratory depression, which is what we call an overdose medically speaking, right? When you were overdosing, the part of your brain that remembers to breathe when you're not thinking about it turns off, so you just stop breathing. Buprenorphine's max effect is below that threshold, so it's incredibly difficult to overdose on buprenorphine alone. Buprenorphine's also long-lasting. Suboxone, which is a combo product between buprenorphine and naloxone. People often think that the naloxone, aka Narcan, that the blocking effect is from the Narcan. That is not true. The blocking effect is from the buprenorphine itself because of how tightly it binds. When the buprenorphine is on the receptor, it is incredibly difficult for anything else to knock it off. The only reason the naloxone is there is to keep people from injecting buprenorphine. Because if you take the medication the way you're supposed to, underneath your tongue, the naloxone will not absorb. But if you tried to inject the medication, then it would absorb and you would Narcan yourself. All right. Oh, perfect. Okay. Do I have a laser? Oh, yeah.
Do you?
Maybe? I don't know. Oh, very small. Okay. So this is the fatal respiratory depression. This is the max effect of buprenorphine. So this is just showing you guys that the max effect levels out below the threshold for an overdose. Okay. So naltrexone. Naltrexone you probably know better by its brand name Vivitrol. This is an injection. Naltrexone binds the receptor, but it does not turn the receptor on. It turns it off. It's like a helmet. Okay? Once naltrexone is on there, nothing else is going to get on. Naltrexone is very, very, very high affinity, the highest affinity of any of the things that we've talked about. So this is a long-acting medication and injectable. It's administered every 28 days. Because the receptor is totally turned off, you need to have no opioids in your body when you start this. If you have been using short-acting opioids like oxycodone or heroin, you would have to be off those for at least 7 to 10 days. If you're using a long-acting opioid like methadone, buprenorphine, or chronic fentanyl, you'd have to be off for 10 to 14, emphasis on the 14. So we're very rarely seeing people get on this for opioids unless they're coming out of a supervised setting, like a correctional setting, essentially, because it's incredibly difficult to be sober for 14 days without using otherwise. Because naltrexone does not turn the receptor on, if you stop taking it, you will not have withdrawal. But also because it does not turn the receptor on, it will not help with withdrawals, and it's very unlikely to help with cravings, right? The reason methadone and buprenorphine help with withdrawal and cravings is because they turn on the receptor. Naltrexone just turns it off, okay? Generally, when people are on naltrexone, they don't feel any different. You don't feel different from being on naltrexone unless you tried to use something. Because if you tried to use something, naltrexone would block it from binding. That's the only way that you would feel it. Okay, naltrexone does not maintain your opioid tolerance. So just like detox, just like jail, if you're not on medications while you're in those, when you're on naltrexone, if you stop getting it, if you overdose after, you will be more likely to relapse or overdose and die. This is not recommended in pregnancy. The other two are, methadone and buprenorphine. And probably my last point. So this is very, very difficult to get onto. It's also the only option we've talked about that does not decrease mortality. So methadone and buprenorphine make you less likely to die. Naltrexone does not make you less likely to die, unlikely to help with withdrawal, unlikely to help with cravings. For all of those things, I would say that this is never the medication that I go to first if I'm thinking about starting someone on a medication. I will say that naltrexone has excellent evidence for alcohol. Just something to be aware of. If people are on naltrexone for alcohol, they have less drinking days per month, and on the days they drink, they have less drinks. Okay. So buprenorphine, but this is the extended release injection version. So there's 2 types of buprenorphine injections. These are long-acting. You can get them weekly or monthly. Their brand names are Sublocade and Brixadi. If you're going to be on Sublocade, you have to be on buprenorphine for a week before you start it, basically to ensure that the medication doesn't make you sedated before I give you a long-acting injection, right? Because I can't have you be sedated for 28 days. It's very uncool of me. Brixadi, you only have to tolerate 1 single film. And if you can tolerate that film without going into withdrawal, then you can start on Brixadi weekly same day. The injectables do provide higher blood levels of buprenorphine than the films. So if you were having withdrawal on max dose Suboxone, which is the films, you could try the injectables before trying methadone if you wanted to give that a shot first. If a patient wishes to stop buprenorphine, the injectable, there's no tapering process like we would do with methadone, like we would do with Suboxone films. You can simply stop getting it. After someone stops getting the injectable buprenorphine, the medication can remain on their urine drug screen for months. Super, super important to know. If someone's on Sublocade or Brixadi and they got it 6 months ago, or they stopped getting it rather, and now they're seeing you and their urine drug screens are positive for bup, it's probably because of the Sublocade. They are not lying to you. Okay, so some common misconceptions about MOUD. This comes back to what I discussed earlier about behavior. So when someone is using a short-acting opioid like fentanyl or heroin, they typically wake up sick. Like generally, it's the feeling of sick that wakes people up, right? They have to think right away about either using or getting the substance and then feeling better and then having it wear off and kind of going through all of that again, right? As is illustrated by this fun thing that I clearly made myself, it makes it really difficult to think about anything else because almost all of your headspace is taken up by thinking about the substance. But if you're on a medication like methadone, buprenorphine, you wake up in the morning not in withdrawal, 24 hours goes by and you dose again, and you're not in withdrawal, right? So rather than thinking about taking something all day, you're going to be thinking about taking this once a day when you go in the morning to take your medication. I think, and so the point of this is to me that truly exemplifies why the behavior around the medication is totally different than the behavior around a short-acting like heroin or fentanyl. So this comes up a lot. What is the right length of treatment? So there is no research that tells us this is exactly the right length of treatment, but the research does tell us that more treatment is typically better than less treatment. I think the easiest way to understand that is to know that it takes time to build the habits that make up a sober life, right? Being sober is more than just being on medication. Like, do you have a job when you're sober? Do you interact with your parents now? Did you get your kids back? Do you live in the same place, or did you have to move away to get away from your dealer? All of those things are things that people are thinking about when they're becoming sober. So typically if people get stable on the medication, they try to taper right away. It's simply they did not give themselves enough time for their lives to change, and people generally relapse if taking that route. So all that being said, the research shows us that anything less than a year is not effective. 3+ years is ideal. Globally, out of all the people that start MOUD, 25% taper off and are abstinent indefinitely. 25% continue to take medication indefinitely. 50% go on and off MOUD repeatedly. Yeah, I think this last bullet point here was going to say that basically the research is even better for people that are on medication for 5+ years.
Sorry about that.
You're totally fine. Okay. Oh, we got a cue. So, but my patient, all right. But my patient was buying buprenorphine, methadone off the street. I shouldn't prescribe them something they were getting high on, right? This comes up a lot. So the research shows us, like what they've gone out and they've asked people that are buying medication off the street, why are you buying this, right? And overwhelmingly, the reports they get back are that people are trying not to be in withdrawal and they don't want to be high, so they're buying this medication instead. So to me, if someone tells me they're buying meds, like if someone came in and was like, Hillary, I've been buying Suboxone 16 milligrams a day. It's perfect. I don't have any withdrawal. I'd like to start treatment. I would feel like that person did my job for me, right? They already know what dose of medication is right for them. They have the same goal as I do, like for them to be sober. So I'm going to start that medication. I'm not going to label them drug seeking, right? Just the same way, like if I had a patient come in and be like, I'm using my aunt's insulin because I couldn't afford any, I wouldn't be like, you're drug seeking. I would be like, you need insulin, right? Because you're diabetic. Okay. So like length of treatment, the research also shows us that higher doses of medication tend to work better. So there is no perfect dose of medication. But again, the right dose is one that lasts 24 hours, treats your withdrawal, it doesn't make you drowsy or high. But typically, those doses that work better are high or are on the higher end. Just something to be aware of. I bring that up because typically when I'm talking to patients, when they're telling me about stigma that they encounter in the community, it's often around the nature, like how many milligrams their dose is. But my response would be to all of you, remember that higher doses tend to work better. Okay, so what are our goals of a MOUD? No, we're good. Okay, I think this is good. Okay, so I'm very harm reduction focused, and that's the way I was trained. This has always made sense to me. So when I'm thinking about goals, I'm basically thinking about any positive improvement, right? If a patient is coming in and telling me they were using a gram a day and now they're using a half gram, I'm excited. I've had patients buy apartments using a half gram a day, which they couldn't do on a full gram, right? So that's a huge improvement. I'm more excited about people not committing crimes anymore to buy heroin. I'm excited about stable relationships. I'm excited if you were using IV and now you're snorting, because all those things are better for you. I'm much more focused on this and things that tell me about someone's quality of life than I am on how many medical appointments they go to, how many counseling appointments they go to, or whether your drug screens show, right? Because one of those is telling me whether somebody's life is getting better, I think these things, and the others are just data points. Okay, Okay, so person-first language. Person-first language is the idea that when we're talking about people, we should not define them by their illness, just because it's not very nice, right? So if we're talking about someone who has a substance use disorder, try not to use words like junkie, addict, user, or alcoholic. That person is so much more than their medical history. Try to say things like a person with a substance use disorder, or a person with an opioid use disorder, or an alcohol use disorder. Likewise, humans are not clean or dirty. They're just humans. So try not to use those words when we're treating people. If we're talking about urine specimens, you could say positive or negative, normal or abnormal, appropriate or inappropriate. If we're talking about humans, you could say a person who is in or out of recovery, a person who is currently using or not using substances. If we're talking about a syringe, we could say used or sterile rather than clean or dirty. Okay, so these are the heading here that was on the left said something like, I think recommendations are...
How can I collaborate with MOUD
Oh my God,
providers?
thank you so much. How can you collaborate with MOUD providers? Okay, so when someone is getting methadone or buprenorphine from an opioid treatment program, it doesn't go to a pharmacy, right? They get it's dispensed from our clinic. So that medication will not be in the prescription drug monitoring program. So if anyone here is a prescriber or is thinking about prescribing, know that you will not see those medications there unless we have an ROI and we call and tell you. If you are aware that someone is getting a medication like methadone or buprenorphine, know that being on those medications does increase your overdose risk, right? They are opioids. So if you're prescribing benzos or other sedating medications alongside them, please approach that with caution, right? If you're on methadone, if you're on other sedating meds like Ambien, Xanax, another opioid or something like that, those things would increase the overdose risk, so please be judicious about that. I alluded to this earlier, but if you are not the medical provider managing a medication like methadone or buprenorphine, try not to comment on the dose, right? The dose of that medication is between the patient and their provider. Those are the only two people who know if it's the right dose. When patients tell me they feel discriminated against in the healthcare system, this is, I would say, the number one thing that they say. The third bullet point says, refrain from projecting your own opinions onto another person's recovery journey, right? If someone's picking up a new exercise regimen, I don't tell them they should run marathons because I do that. I'll just be like, oh, you're doing Zumba, or oh, you're walking. That's great for you. That's fantastic. You should pick something that works for you. But I think universally, like if you came up to me and were like, Hillary, you should do Zumba, I would be like, I hate Zumba. I'm not doing that, right? And similarly, if someone has an idea of what their recovery journey should be and the best path for them, like that's for them, right? The only person or a person's recovery journey only has to make sense to the person who is on that path. So try not to, I guess, project your opinions on that. MOUD is held to a higher standard of confidentiality than other types of medical care by federal law, so just something to be aware of. Like if you were to call our office and say, Hillary, I want to talk about your patient X, if I don't have a signed ROI in front of me, I can't even acknowledge that person is in treatment with us because that would be a violation of protected healthcare information. The next one says treat MOUD the same way you would treat insulin. I know that I've made a lot of analogies about that, but I think the point here is that opioid use disorder is a chronic medical condition, just like diabetes. We know from the research that if we're looking at all chronic medical conditions along the course of a person's life, 50% of the time they'll have that condition controlled and 50% of the time they won't. I think the point here is that if you wouldn't say something about insulin or make a judgment about insulin, then don't make that judgment about methadone or buprenorphine. And then last, take every opportunity you can to remove barriers to treatment. I would say that the people that we're treating, people with opioid use disorder, are some of the most stigmatized, marginalized people that I've seen in the healthcare system. I have heard people say things, and in my career, I've heard people say things like, well, they don't need that extra help. They can do that part themselves. We don't want to spoon feed them. We don't have to do everything for them. And I guess what I would say in response to that is that if someone has an active substance use disorder, they do need every little bit. You should do every little bit. I think every little bit counts, and every hurdle that we can remove to getting someone into treatment is worth doing. All right, I think that's the end of me.
Yes.
Okay, perfect.
It is.